Assalamu alaikum wa rahmatullahi wa barakatuh. Very good day and welcome to Life Matters, where we explore the journeys that shape us, the wellness to heal us, and the stories that inspire us. In today's health edition, we shine a light on liver health and disease. Joining us is the esteemed Professor Wendy Spearman, a leading hepatologist and expert in viral hepatitis. With her wealth of knowledge and experience, we delve into the world of liver disease, exploring topics like hepatitis B and C, and the latest advancements in research and treatment. We'll learn how to prioritize our liver health and support those affected by these conditions. Don't forget to interact with us as well. We have our social pages available. We will be having an app launching soon as well. Very excited about that. But if you have family, friends, and colleagues watching across or living across the lands and over the beautiful seas, please tell them that they can join us right now live on Hilaal.tv. So our WhatsApp line is available and our social pages as well to interact, to send any comments, questions and queries that you have maybe around liver disease or what you'd like to hear or listen to on Life Matters in our next show. So thank you so much for tuning in and stay tuned. We're now joined by Professor Spearman. Thank you so much, Prof, for joining us and welcome to the show.
And thank you very much for inviting me and really to be able to share my passion about liver disease and how we can actually address it and treat it appropriately.
Absolutely.
I mean, I've been a practicing hepatologist since 1994, and I've really seen the sort of real expansion of therapeutics for liver disease and how we can actually now more easily diagnose liver disease, actually appropriately treat it, and if necessary, embark on liver transplantation. But obviously, always the aim is actually to diagnose liver disease early, treat it appropriately so you can avoid liver transplantation.
Absolutely. And I think this is a show that we'd like to create awareness and get that conversation going. So let's first introduce, our viewers that are not aware of the importance of the liver function in our bodies. Please, Professor Spearman.
So I like to think about the liver as sort of the powerhouse of your body. Obviously, I'm a hepatologist and I'm biased, but really the liver plays an extremely important, really part of where your body works. So it's involved in actually making the appropriate proteins. It's involved in sort of carbohydrate and fat and protein metabolism. Very importantly, involved in immunity. So people often don't realize that if your liver is not working properly, your ability to fight infections is actually impaired. The other important component is actually detoxification. So not only does it detoxify potential toxins that you're exposed to, it also is very important in actually metabolizing drugs. And that's why it's very important if you have an underlying liver disease to be aware of the fact that certain drugs are more likely to be toxic to the liver. So one should always discuss that with your healthcare provider if you have liver disease. Are these drugs safe for you? Other important thing is obviously clotting. It's important that it actually ensures that you're able to clot properly, and importantly, also involved in ensuring that your sugar levels remain stable. So it really has multiple functions. And once the liver is actually severely affected, progressing to advanced fibrosis or cirrhosis, it has a knock-on effect on other organs, particularly the kidneys and the heart and the brain. So it's really important that one recognizes liver disease early, does not ignore abnormal liver enzyme results, and actually tries to find what is the underlying cause, address it, and treat it appropriately.
So with your involvement with the WHO, can you share your insights on the current state of liver disease in Africa and how initiatives like the projects you're involved in, the one specifically ECHO, are making a difference in the lives of those suffering from liver conditions?
One of the roles of the WHO, particularly in liver disease, is actually to develop guidelines for hepatitis B and C that are appropriate for low-income countries, and so that they can be implemented and address the burden of disease. So we look at the burden of disease in terms of hepatitis B. There's about 67 million individuals that actually are infected with hepatitis B within Africa, but less than 4% have actually been diagnosed and less than 1% have actually been treated. Similarly, for hepatitis C, we have curative therapies, but in Africa, there are about 54 million individuals infected, and once again, less than 20% have actually been diagnosed and less than 5% treated. So we have this burden of disease within Africa for two hepatitis B and C, which are easily diagnosable, are amenable to prevention for hepatitis B, treatable for hepatitis B, and curable for hepatitis C. So one of the big problems with hepatitis B, which the WHO recent guidelines of 2024 was really to try and demystify management of hepatitis B. Yeah. So if you're a hepatologist, you really like to understand the virology, there's different phases of infection, and then decide, depending on the phase of infection, does the individual need disease. But if we're going to address hepatitis B, particularly the burden of disease associated with cirrhosis and liver cancer, which affects young individuals, we need to actually decentralize, integrate it with primary healthcare services such as HIV, TB, and move the treatment of uncomplicated patients with hepatitis B to the communities. And so one needs to actually have guidelines that are implementable. And so the way the WHO have now addressed these new guidelines to have really 4 easy to address, easy to understand criteria for the initiation of treatment. And so top of the list is really, do you have advanced fibrosis and cirrhosis? And the importance of that is because that increases your risk of liver cancer. And so how do you diagnose whether you have advanced fibrosis and cirrhosis? It's very important that you have a scoring system that actually can be utilized at primary health care. So we have a very simple scoring system called the APRI score, which takes into account the AST level, which is a liver enzyme, takes into account the platelet level, and looks at a score. If it's greater than 0.5, that increases your risk of having advanced fibrosis. And then it doesn't really matter what level the virus is, what the level of your ALT is, you will treat those patients regardless. And that's very, very important. And that's particularly important because of the burden of liver disease, which progresses to liver cancer within Africa, usually in young males, often in their 20s to 30s, and often presenting with inoperable liver cancer. One of the other indications is if you have any cofactors. So if you've got a family history of liver disease, family history of liver cancer, if you have other cofactors such as steatotic liver disease, if you're on immunosuppression, once again, you treat regardless. Doesn't matter what your level of replication is or your ALT is, you treat those individuals. And then those who have evidence of disease in terms of having an abnormal ALT level and a viral load greater than 2,000, you will treat those. But very importantly, if we look within South Africa, within Africa, access to actually quantifying that degree of hepatitis B viral replication is extremely expensive and is not actually available at primary community care level. So there, if you just have an persistently abnormal ALT and you're documented as having hepatitis B surface antigen positivity, you will treat. So you can see we've actually tried to demystify the criteria for treatment, make it easily implementable, particularly at primary care and community care level. And the similar thing for hepatitis C. They've really tried to simplify guidelines and wherever possible actually have it as a test and treat. So you actually go to the community center, if you're hepatitis C, antibody positive, you confirm viremia, and then you initiate therapy. So really trying to simplify treatment algorithms so they can be easily followed and implemented.
Wow. So much to learn from just that information, Doc. Professor Rather, what are some of the common types of liver diseases and what are the risk factors for those liver diseases?
So if we look at probably the most common causes of liver disease, we're going to start with the viruses. And here we're looking at viruses A, B, C, D, and E. And these are viruses that primarily affect the liver and so cause damage called inflammation, and if they're not addressed, advance to fibrosis and cirrhosis and liver cancer. Just briefly getting out of the way, the 2 acute hepatitis, which is hepatitis A and E, and those are usually as a result of fecal-oral contamination. Hepatitis A tends to be quite endemic in South Africa, often acquired in early childhood, completely asymptomatic. So if you're living in a rural area with poor access to sanitation and safe water supplies, often by the time you reach your mid-teens, you've already been exposed to hepatitis A. As opposed, if you're living in an area where there's good sanitation, access to water, you usually will then acquire that in adulthood, and then it presents as an acute illness with fever, nausea, vomiting, and jaundice. Hepatitis E is also an acute viral hepatitis. That's very interesting. Initially, it was thought only to be a problem sort of in the Southeast Asia, but we know it's actually quite endemic within Africa, particularly because also as a result of fecal-oral contamination, contaminated waters, we see a major problem in patients, in refugees and internally displaced persons who have poor access to safe water and hygiene. And one of the Problems is for hepatitis E, although there's a vaccine, this is actually only registered in China and is not actually easily accessible across Africa, as opposed to hepatitis A, which is a vaccine-preventable disease as well. So those are the two sort of acute viral hepatitides. But the main problems that lead to sort of chronic liver disease are hepatitis B, C, and D. Just getting hepatitis D out of the way, this is a very interesting virus in that it actually is a defective virus. It requires hepatitis B to actually replicate and divide. And so you can either have hepatitis B and hepatitis D occurring at the same time, or somebody with chronic hepatitis B then acquires hepatitis D. Fortunately, in South Africa, our risk of hepatitis B is very small, less than 1% prevalence, and we see it mainly across the Central and West Africa and going north. So hepatitis B is not a big problem in South Africa.
Okay.
But hepatitis B is a major problem. Hepatitis B is endemic in South Africa, nearly 5% seroprevalence, and is estimated at about 2.7 million actually infected with hepatitis B.
Sure.
And this is once again a problem because only about 20% are diagnosed and less than 1% are actually being treated.
Sure.
Scary
stats.
Yeah, scary stats, particularly when you think that hepatitis B is entirely vaccine preventable.
Wow.
And I think obviously, whenever we think about any kind of disease, we need to think about prevention first before treatment. And I think just going into prevention of hepatitis B.
Before you do that, Professor, we just quickly need to pay the bills. When we come back, unfortunately, we need to take a break quickly, and this topic is just getting very, very interesting, understanding what our current situation is of liver conditions and liver diseases. And Professor just touched on the viruses, not even the diseases yet, but we'll talk more just after the short break with Professor Wendy Spearman. Stay with us. Welcome back to Life Matters. Today we're talking about the unsung hero of our body, the liver. This vital organ works tirelessly to detoxify and energize our body, making it a crucial component of our overall health and well-being. Let's continue to dive into the fascinating world of liver function and exploring ways to support and nurture this essential organ, because a healthy liver matters. And just before the break, we were chatting to Professor Wendy as she was giving us some staggering stats as her involvement with WHO and an organization called ECHO. And just before the break, Prof, you were talking about hepatitis B and how it can be prevented. Let's continue that conversation.
So I think it's really essential that we need to realize that hepatitis B is an entirely vaccine-preventable disease. And in fact, the hepatitis B vaccine is a cancer-preventing vaccine.
Sure.
So in order to understand the importance of the vaccination, we need to understand how hepatitis B is transmitted. So predominantly transmitted mother-to-child transmission or early childhood acquisition under the age of 5. And so if we look at the vaccination, it's extremely important that you actually identify mothers who are hepatitis B surface antigen positive, decide whether they need treatment to actually prevent transmission because they're highly viremic with very high viral loads, or they need treatment in their own right. And so if they are highly viremic, we need to actually ensure that we can decrease that replication, and then we start them on tenofovir, which is an antiviral agent, and we start that in the second trimester. But very, very importantly, the neonate has to be vaccinated at birth, and that has to be given within 24 hours of delivery. And if you combine that, the tenofovir prophylaxis in the mother, the birth dose vaccine, and then followed by the usual 3-dose hepatitis B vaccine, which is given as part of the expanded program of immunization schedule at 6, 10, and 14 weeks, and boosted 18 months, you then can actually prevent hepatitis B in over 99% of cases. So extremely important. In South Africa, we were one of the first countries in Africa to introduce universal hepatitis B vaccination at 6, 10, and 14 weeks in 1995. But in fact, we had not introduced a birth dose vaccine. Fortunately, last year, the Ministry of Health actually decided that we would introduce the birth dose vaccine. And at present, we're giving it targeted vaccination. So all mothers are screened for surface antigen positivity, given tenofovir, and babies born to mothers who are surface antigen positive will receive the hepatitis B birth dose vaccine. But our next real sort of role is really to persuade our Ministry of Health to actually have universal birth dose vaccine. I think that is, we've shown worldwide, is extremely cost effective in preventing hepatitis B. And then we have very adequate therapies in terms of tenofovir. Unfortunately, we don't have curative therapy, and tenofovir at present is actually lifelong therapy, but highly effective, prevents the progression to cirrhosis, can reverse advanced fibrosis, and can prevent liver cancer.
Let's talk about the impact of our overall health, our everyday life, and how lifestyle changes can help manage liver conditions and liver disease. Because specifically you spoke about the liver viral infections. Are there any other liver diseases that you would still like to touch on?
I think just briefly to mention hepatitis C, which now we have curative therapy for. It's a very simple diagnosis, an antibody test confirming viremia, and then you start treatment with direct-acting antiviral therapy. The importance of this is actually it's really very short course, 12 weeks, and there's over 90% chance of actually achieving a cure. And very importantly, all individuals who are hepatitis C infected are candidates for therapy. So as opposed to hepatitis B, where we still actually decide on criteria, for hepatitis C, if you're infected, you need to be treated. For hepatitis C, I think we need to remember what the key populations, vulnerable populations, were actually affected by hepatitis C. And those are individuals who inject drugs. And unfortunately, we need to be providing better harm reduction services for these individuals. So one needs to ensure that we have safe needle exchange programs and opiate substitution programs. And at the moment, that's mainly supported by NGOs. But once again, we need our ministries of health to actually take this on and effectively actually drive these programs, because unless we actually address this problem, hepatitis C is not going to be eliminated from South Africa or across Africa.
Prof, could you expound on some of the recent advancements in liver disease research and treatment? You've mentioned some of the initiatives that has been created last year with the vaccines. What advancements in research on with regards to treatments are there?
So I think the main sort of advancements in treatment, I mean, obviously for viral hepatitis, we have effective antivirals now. But I think the real advancements have actually been in the field of metabolic dysfunction associated steatotic liver disease, which used to be called non-alcoholic fatty liver disease. And the nomenclature has been changed to be sort of less stigmatizing, but also importantly to really recognize the driving metabolic risk factors for metabolic dysfunction associated steatotic liver disease, which is obesity, diabetes, dyslipidemia, and hypertension. And you mentioned earlier, how does this actually affect lifestyle? And I think this is the one disease actually which has a significant impact in terms of lifestyle and in terms of actually how we can actually adjust our lifestyle to decrease the risk of developing MASLD or actually improve the outcomes of MASLD. And so here, definitely, I mean, one of the big problems of MASLD is that not only does it affect the liver, but it actually affects the body as a whole. So you have this increased risk of cardiovascular disease with myocardial infarctions, cerebrovascular disease with strokes, chronic kidney disease. So it actually affects, it's a liver disease. It actually has a multi-organ effect if you don't address it properly. And if we look at globally, it's now the leading global cause of chronic liver disease globally, affecting almost 1.6 billion people. And we know within Africa, including South Africa, that obesity and diabetes mellitus is actually increasing in prevalence. And these are very important risk factors for developing MASLD. And here really we're looking at lifestyle in order to actually address that. But you mentioned in terms of development, I mean, we've had really exciting developments in terms of therapeutics, not only for actually addressing the diabetes and obesity, but in March of this year, we had the first FDA-approved drug for metabolic dysfunction associated steatotic liver disease, if you've got active inflammation and advanced fibrosis, but not if you have cirrhosis. And this is called resmetirom. This is the first approved drug for fatty liver disease, and very importantly, actually improves outcomes in terms of cirrhosis, but also in terms of cardiac outcomes. Yeah. So this is very exciting. once again, is it going to be available to those who need it? So we don't know exactly what the costs are, certainly not registered as yet here in South Africa or in Europe, mainly in the States. But one of the important things that we always see with these drugs is the inequity in terms of actually equal distribution and access to everyone. And those are something that we need to actually be working on. In terms of the diabetes and obesity, I'm sure you've all heard of the semaglutide, which is the sort of wonder drug associated with significant weight loss, but also improvement in diabetes, and in terms of has improved cardiac outcomes. And at the moment, in fact, it's almost impossible to buy semaglutide because it's been so popular. The stocks of it within the country are quite limited. So these are really groundbreaking developments in this disease. Once again,
Professor, the semaglutide, is that the other name for Ozempic? Because that's the name we've been using.
Yes,
okay.
Yes. So, I mean, the problem is obviously costs, and can you actually get it to? I mean, it needs to be available to everyone, and that's one of the problems.
Especially those that need it.
Yeah, with pharma, and if we just look at the rise of non-communicable diseases. And the impact that has on health economy, I mean, we really need to actually address that in terms of what are the appropriate drugs that actually can address this problem effectively.
Yeah. Let's talk about, in your opinion, how we can support those affected by liver disease. What are some of the most common misconceptions about liver disease?
So I think one of the problems about liver disease is that it tends to be a silent disease. So by the time you actually present with complications, they're almost well established. They have cirrhosis, complications, then what we call portal hypertension, you have GIT bleeding, you have ascites of abdominal swelling, liver cancer. And so one of the problems is that if you have abnormal liver enzymes and you have a routine check and you know to have abnormal liver enzymes and you're feeling well, often it's not actually addressed. The underlying cause is not actually just found and not actually addressed. So very importantly is to remember that liver disease is entirely silent clinically until you develop complications. So we need to have an actual awareness. And so there's a program now that has been developed by the European Association Study of Liver Disease together with other liver societies known as Healthy Lives, Healthy Livers. And one of the things here is actually to address lifestyle. Okay. So looking at in terms of your weight, your exercise, your diet, really addressing that, try to actually improve lifestyle, which actually then has a positive effect in terms of not developing steatotic liver disease or improving the outcomes of steatotic liver disease. So we just look at simple weight loss. I mean, it's obviously difficult, but if you've got established fibrosis or cirrhosis due to steatotic liver disease and you have a 7% weight loss, in fact, that can be effective actually in reversing fibrosis. So very importantly, and if we look at exercise, we need to actually explain to individuals what type of exercise you need. So you need cardio plus resistance. And you need at least 30 minutes a week of cardio, 30 minutes a session, at least 5 times a week. So it has to be regular. And one needs to find types of exercise that is actually suitable for individuals. Obviously, many people take out gym
memberships. Never go.
Membership, but never go. And so one needs to actually make it as part of general lifestyle, part of family lifestyle, because I think most of us realize if you have a problem of increased weight, it's often many individuals in the family have it. And so this needs to be not just one person, but a family approach. Yeah. So importantly, looking at the diet, the Mediterranean diet is what is recommended, which is really looking at sort of vegetables, fruit, grains, and avoiding or decreasing your sort of red meat intake, fat intake. So very importantly, just looking at a balanced diet. And I think people often think that they need to have these expensive diets, but really one just needs to look at a balanced, healthy diet.
Yeah.
The important thing, I mean, what we've seen which has really driven the problem with steatotic liver disease is this consumption of fast foods, soft drinks, and very high fructose drinks. So often we think that a fruit juice is healthy, but in fact the amount of calories in that is actually quite significant. So we need to be looking at that. And then for the coffee lovers, that's really been shown to actually decrease the risk of advancing fibrosis, but you need at least 3 cups of coffee a day. So for the coffee lovers out there, coffee is good.
Plus for you. Prof, we need to quickly to pay the bills. When we come back, we'll take a short break. We find out how the Society of Liver Disease of Africa is impacting, the management and research with regards to this, and also touch a little bit more on liver hepatitis B and C as well, and keep the conversation going with regards to correct immunization, having the immunizations when babies need it. The stats that Prof actually spoke about is alarming, so we need to take action. We'll talk more on liver awareness just after the short break. Welcome back. We have online Professor Wendy Spearman, a leading hepatologist and expert in viral hepatitis. With her wealth of knowledge and experience, we're definitely learning so much about hepatitis B and C, the liver diseases and the viral infections that affects our liver, and how it can actually be prevented, how we can look after ourselves, and how we can just educate those around us about the function of our liver and how important it is, as well as doing the necessary immunizations at birth as well with the babies. So speak to your domestics, speak to your helpers, check in with them, have they got the correct information? And sometimes they are the ones that we need to help out. We have social media, we have our books, we have our conversations going and seeing our doctors regularly, but sometimes those that needs the help in the outlying areas don't often have that information. So let's reach out to those right at our doorstep that we can pass this information on to. So I have online Professor Wendy Spearman, as I said earlier on. Professor, if I could touch on the Society of Liver Disease in South Africa, as Vice President of this organization, how do you see the society impacting liver disease management and research in Africa?
So the Society of Liver Disease in Africa was established in the beginning of 2023. And the whole aim of that was actually to link clinicians and researchers across Africa so that one could actually share platforms for research, education, and really enhance the ability of our young researchers to have a platform to actually interact with more established researchers and clinicians, both within Africa, but as we also align to the international societies of the American Society for Liver Disease and the European Society, as well as the Latin American Society, that also actually enables them to have interactions with hepatologists, gastroenterologists, clinicians, and researchers across globally, and which is really very important to actually establish those networks, enable them to actually develop their own profiles, and importantly, have a platform to actually present their clinical work and their research. So we have an annual meeting called the Conference on Liver Disease. That started actually in 2018. And we actually have those in different regions within Africa so that we actually cover the whole of Africa. And the next one is going to actually be in Cairo in September. So very importantly, I think that one of the problems that we often see is that if we look at the other international guidelines developed by those societies, they're obviously Euro or American centric. And what we've seen is that, in fact, liver disease in Africa is often very different in its manifestations and its risks. So one of the sort of simple things that we found when we looked at hepatitis B across Africa, we found that the original advice in terms of the ACRI scoring system that I said of greater than 2 actually missed 50% of individuals who had cirrhosis in Africa. As a result of that, we were actually able to influence the recent WHO guidelines to decrease that score to greater than 0.5. So very importantly, it enables the researchers within Africa to actually present relevant data from their own regions, which actually then can influence guidelines. Project ECHO, I think, is a wonderful program. Actually, it was established by Sanjay Barora, a gastroenterologist in New Mexico. We really recognized that patients with hepatitis C were not being treated. By the time they presented, they had advanced disease and often liver cancer. So it's a telemetry program, which is actually really aimed at actually delivering expert healthcare to underserved communities across the world. And so we run a Project ECHO viral hepatitis clinic with the expert hub being here at the liver clinic at Groote Hospital. And we interact with community spokes within South Africa, but also across sub-Saharan Africa, reaching about 20 different sub-Saharan African countries. And this involves having sort of a 15-minute didactic lecture around a problem. But most importantly, clinicians will present their cases that they are struggling with. And we as a team can actually address those complications, address and advise on treatment management, but also in a which is relevant to resource-limited regions. And so we've expanded this now also to one of our correctional services, but also to our opioid substitution programs across South Africa. So this is a very effective way of actually delivering expert healthcare to regions that don't have easy access to academic hepatologists. And anybody's welcome to join this. So we have healthcare workers listening in. They're very welcome to actually join Project ECHO just to learn or to share cases that they feel they need help on. So it's really meant to improve healthcare delivery to all.
Yeah, and although you've just retired at the Department of Medicine as head of the Division of Hepatology, I'm sure you're going to still be very much involved being a co-lead for Project ECHO. So I hope the Almighty just spares you so much more years and energy to get involved in that.
Lots of work to still do.
Yes. Professor Spearman, let's talk about hepatitis B and C a little bit more. You've mentioned how it's been transmitted, how it can be prevented. Let's understand the symptoms and how it's diagnosed.
Okay. So one of the symptoms, so hepatitis B, it will depend on when you acquire it. If you acquire it from mother to child, the risk of chronicity is 90%. If you acquire it under the age of 5, risk of chronicity is 30 to 50%. And if you acquire it as an adult, less than 5% of individuals will develop chronic infection. The big problem is that if you acquire it mother to child or early childhood, in fact, it's completely asymptomatic. Only adults who are immunocompetent who acquire hepatitis B as an adult, and then it usually might be from, let's say, potentially a needle stick injury or sexual acquisition, then those individuals tend to be symptomatic. So they'll have nausea, vomiting, loss of appetite, jaundice, fever. But that tends to be self-limiting if they are adults and are entirely immunocompetent. The real problem is those who acquired mother to child or early childhood and only present in adulthood, often, unfortunately, as I've mentioned before, with multifocal liver cancer involving both lobes of the liver, which is not amenable to any form of curative therapy. And so we really need to have an approach that, in fact, we need to be effective in actually rolling out our preventative programs, particularly the birth dose vaccine. But we also need to realize that those individuals who are potentially at risk, so if you're a healthcare worker, if you're working in a laboratory, if you're a paramedic, it's important to know what your status is. So are you hepatitis B surface antigen positive? Have you been effectively vaccinated? Do you need a booster vaccination? So we need to increase the awareness, just like we did for HIV, where, it's not everybody knows you should know your status and then address it appropriately. We need to actually develop that sort of awareness, know your hepatitis B status, and if you're at risk of hepatitis C, know your hepatitis C status.
The treatment options that are available for those suffering from hepatitis B, Prof.
Yeah, so hepatitis B is an antiviral agent called tenofovir. It's very well known in terms of it's a component of the HIV 3-in-1 treatment, but for hepatitis B, you just need a single agent, tenofovir. It is lifelong therapy. There are some potential side effects in terms of renal impairment, but that's really if you have an underlying renal impairment, and there you can actually use another option called tenofovir alafenamide, which is a prodrug of hepatitis B. We're extremely fortunate here that we have access both to tenofovir and tenofovir alafenamide. And so one needs to actually, I think very importantly, one of the problems that individuals have when they're diagnosed with hepatitis B frequently is when they go and donate blood at the blood transfusion service, told they have hepatitis B, and then come and see us. And they're completely asymptomatic. So one needs to actually explain to this young individual or middle-aged individual that, in fact, you have hepatitis B. We can't cure it, but we need to put you on lifelong therapy. And so one needs to actually, one of the things with hepatitis B, you have time to actually educate, counsel, and importantly, one of the other important preventative aspects is actually to screen partners, screen siblings, and screen children, because this is really a point where you can actually prevent and break cycles of infection. When we often have families where a number of them are hepatitis B infected, and a number of them have actually developed HCC and even liver cancer and even died from that. So identifying that individual is another important point of contact where you can actually screen other individuals in the family and break cycles of infection. But tenofovir therapy is lifelong therapy.
And with regards to the treatment, is there any specific lifestyle changes or adherence specifically when it comes to those treatments of Hep B?
Yes, so very importantly, the treatment you need to be strictly adherent to it so that you don't have breakthroughs or rise in the hepatitis B viral load, which then can result in significant flares and further damage to the liver. But importantly, you need to realize that if you have any chronic liver disease, there's really no safe alcohol. And so one advises completely against alcohol intake in somebody with chronic liver disease, whatever it is. The other thing is that we often see in patients with chronic hepatitis B who are getting older, not as active, although the hepatitis B is well controlled, you see that ALT level, which is a measure of liver inflammation, slowly rising. And when you address this further, you actually see that they've increased weight, the BMI is increased, and if you do a liver ultrasound, you often might see fatty changes within the liver. So very importantly, that you need to combine the treatment of also, importantly, really healthy lifestyle. That's very important. So it's a holistic approach to the problem.
After the break, we'll elaborate on hepatitis C, again, the transmission, symptoms, diagnosis, treatments, options, and how we need to raise awareness around these liver conditions, diseases, and infections more just after the short break. Stay with us. Welcome back. A very good day to you. This is Life Matters, and every life matters when it comes to liver conditions. So remember to interact with us as well. Any questions, comments, or queries, we have our WhatsApp line and our social media pages are open. And if you've missed this show on liver awareness or any of our shows, you can watch it on our uploads on our YouTube channel as well. So download the show, or save it, and catch it on our YouTube, and then you can send the link through to your friends, family, when they do need to be aware and educated about liver conditions. Online, we have a professor from the Western Cape, Cape Town. Professor Spearman is a practicing hepatologist and recently retired as head of the Division of Hepatology at the Department of Medicine, Faculty of Health Sciences at UCT, University of Cape Town, and Groote Schuur, Cape Town, literally days ago. And she's also actively involved in the outreach liver education program and is co-lead for viral hepatitis in sub-Saharan Africa project called ECHO. Really would like all the medical fraternity that is involved in this industry to get involved in Project ECHO. So let's touch on liver condition hepatitis C, Professor. How is this transmitted? What are the symptoms and how is it diagnosed?
So hepatitis C is very different from hepatitis B, is that if you actually are infected, 75% will go on to develop chronic infection regardless of the age that you acquire it. And so we need to understand what are the transmission risks. As you remember that the mother-to-child transmission of hepatitis B is very high, highly viremic. For actually pregnant women who are hepatitis C antibody positive and viremic, in fact, the risk is only 3 to 5%. But if you have HIV, hepatitis C co-infection, and the HIV is not treated, then the risk actually increases to 11%. Also importantly, the risk of heterosexual transmission is actually very low, less than 5%. But once again, if you are HIV co-infected, then the risk actually increases to 10%. And the risk is really quite significant in terms of individuals who inject drugs. So their there's actually up to a 30 to 40% risk of transmission. So it really varies according to how you actually acquire it, depending what the risk factors are. I think one of the important things to realize that within South Africa, we have sort of two profiles. The older profile, sort of 50 to 70s, and those are usually were acquired as a result of potentially unsafe medical practices, surgical practices, and remembering in terms of the identification of the hepatitis C viruses, this was really only identified in the 1990s in terms of actually adequate diagnostics. So potentially could have acquired it from blood transfusions or blood product transfusions, although our blood service now is really one of the safest in the world. And then we have that young age group, sort of the 20s to 40s, and this is really mainly driven there by people who inject drugs. So we have two sort of main profiles, and very important that we realize that and recognize potential risk factors and appropriate screening. Mass screening for hepatitis C, where we have a prevalence of less than 5%, is less than 1% in the general population, is really not cost effective, but so one needs to know the risks for that. And then in terms of treatment, I mean, I think this has been one of the major breakthroughs in that we now have treatment that can affect all 6 genotypes of hepatitis C, has a sustained viral response rate, which is defined as a cure if you're negative 12 weeks after completing treatment, of more than 95%, regardless of what your underlying problem is in terms of whether you're HIV infected, whether you have cirrhosis, really highly effective therapy. And as I mentioned before, all individuals who are hepatitis C infected are candidates for treatment. So a major breakthrough. And this is really treatment if you have uncomplicated hepatitis C that can be done actually within the community. We know that within the UK, in fact, is often driven by nursing sisters are able to drive these clinics. So really very simple treatment, very few side effects, and highly effective.
Thank you so much for that informative information about hepatitis C, rather. Let's recognize the differences. Professor, could you elaborate on some of the common misconceptions about hepatitis B and C, and how we as a community can raise awareness and promote education?
So I think for hepatitis B, there's often a lot of stigma attached to it. Often it's thought to be sexually acquired, although that is one of the roots. It's really mainly acquired from mother to child or early childhood acquisition. So I think we need to encourage know your status, try and actually address stigma that is actually associated, which prevents individuals from actually seeking care, but also prevents individuals from sharing their status with family members. Because as I've mentioned, for hepatitis B, that's a very important way of actually breaking cycles of infection, to screen partners, screen other family members. So we need to actually improve the awareness and education around hepatitis B and C. For hepatitis C, once again, we need to realize that those who are high risk of developing are people who inject drugs, and we need to actually provide programs within the communities where they can be treated. So really not appropriate for somebody who is injecting drugs to have to come to a clinic, wait for a long time to be seen. We need to actually identify them within their communities. And so we have a very good program such as TB HIV Care. We actually are running these programs for people who inject drugs, ensuring that they have access to harm reduction services, but also potentially access to curative hepatitis C therapy.
So, Professor, as a leading expert in viral hepatology, hepatitis, what are your thoughts on WHO's efforts to combat the disease and your involvement in creating these guidelines in South Africa? And how exactly can we support these initiatives?
I think the WHO guidelines are really addressed to enable low-income countries to implement diagnostic, preventative, and therapeutic interventions. And so they address really it's a public health service approach. So it's addressed really to ministries of health. And so I think very importantly is that we need to actually hold ministries of health accountable, because in fact, as you know, the funding, although in contrast to funding for HIV, TB, malaria, where there's a lot of international funding, there's very limited funding for viral hepatitis. So one relies on domestic funding. And so we have a viral hepatitis management guideline which has been adopted. It's been was adopted in 2019. Implementation always requires funding, and so one needs to actually ensure that there's dedicated funding which is ring-fenced for viral hepatitis. And the other thing is really to integrate it at community healthcare level with other services, potentially HIV, TB. But once again, you cannot add another service onto an existing service. That has to come with dedicated funding. And so I think we need to, if we look at HIV, what turned things around was really the public and community outcry of why we were not being treated, why we were not being diagnosed, why did we not have access to antiviral therapies. And so I think we need to actually raise that advocacy, groups raise their profile so that they can actually really demand access to what is really simple diagnostics and therapeutics. So I think we need to be more, we have to have a more activist approach to actually ensure that we have access to the appropriate therapy. So once again, that involves education programs. And that's what we have via Solder and Project ECHO to improve education around viral hepatitis.
So with that in mind, Prof, your last words, your departing comments, as well as where we can find the correct literature, the correct information on the World Wide Web that's quite vast with regards to liver conditions, liver diseases, and the viral infections involved in it.
So I think one needs, my sort of parting statement is really that one should not be nihilistic about liver disease. Liver disease now can be diagnosed, can be effectively treated, and in some cases cured. We just need to identify it and really need to take away this concept that all liver disease is alcohol driven. I think that's a major misconception and a major barrier to actually addressing the problem. In terms of, how do you access therapy, access knowledge around hepatitis, viral hepatitis or liver disease in general. So I think importantly, the American Society and the EASL Society have very easily readable guidelines, which are actually accessible to everyone. I would really encourage people to join the Project ECHO programs, and we have a number of Project ECHO programs, one for viral hepatitis, but we have others for gastroenterology in terms of liver cancer, liver histology, inflammatory bowel disease. So we have a number of Project ECHO programs running on a weekly basis, and these are really open to everyone to join. So we can give you the context to actually Cheryl Valentine is our project manager who runs these programs and will enable anybody to join as they wish. And then obviously the liver clinic is always open to give advice. We are available on the telephone. We have very easy access to seeing our doctors at the clinic and very, very willing to actually assist doctors or community health workers actually manage patients within their own programs.
And that's specifically at all government hospitals, and this one, Grooteskuur as well. So thank you so much for supporting the staff, the structure of the liver department there, Professor. We hope that the Project ECHO does grow from strength to strength with your involvement. And thank you so much for this information, sharing your expertise and insights rather with us today. Your dedication to liver health and education is truly inspiring. We hope our audience has gained valuable knowledge and understanding of liver disease and management. Thank you for your time, and maybe we can have a follow-up show. Please do let us know about any events or fundraisers or information. Send us the posters so we can keep our viewers informed as well. But all the best till we chat again. Goodbye, Prof.
Thank you very much. Bye.
Bye-bye. That was Professor Wendy Spearman, hepatologist, really educating us on management of liver disease and conditions. Remember, your liver is a precious asset rather, working tirelessly behind the scenes to keep you healthy and thriving. By taking care of your liver, we're investing in your overall well-being. Awareness and education are key to prioritizing our health rather. Let's continue the conversation and support each other in our journey towards better liver health. Stay liver aware, stay healthy. Thank you for tuning in. Join us next time with child educational psychologist Nabila Gangat on how to talk to our little ones about the birds and bees. Until then, stay informed, stay healthy. From the rest of the Life Matters team, wassalamu alaikum and goodbye for now.